And I'm just starting our stream on the DSS YouTube channel. All right, I think should be streaming successfully, and we'll start in just a minute. All right, Greg, seeing here 11:02, we'll get started and just welcome everybody to our August meeting and hope many of you are able to enjoy some of the summer. Commissioner Martin Rees will be joining us shortly this morning again, and joined by several other of our DSS colleagues. But Guy remains out on paternity leave and is planning to return next month. And I had the chance to visit with him recently and his son, and they're doing well, thankfully, just getting used to being new parents, which many of us, I'm sure, can relate to. It takes a little bit of time to figure out. So our last meeting, we reviewed data related to social determinants of health and health-related social needs, and had a listening session on how to address those, and we got a lot of feedback from you. And so today, we'll be talking about things that kind of somewhat in context of that. So we'll be talking, review what we heard from you, review some goals for today, and then talking about the primary care, some examples of primary care payment reform, payment plans that other states and nationally have occurred that may be useful in addressing, kind of linking these things between addressing those needs and what primary care can do. And then we'll also be doing a curated data review and discussion as well, depending on how much time we have left. We'll be focusing on that based off of somewhat of a curated data review based off feedback from all of you. And we've also scheduled that supplementary data meeting, which we'll also be making public and streaming for those who can't join towards the end of August. So on the next slide, one other thing that we've been discussing is we've got some external feedback as well as internally kind of reviewing our current membership, and we wanted to include more individuals with from a broader background and more diversity. And so we've added a few folks, and we are very excited to welcome them today, which not all of them were able to join. First, CJ or Catherine John, and also wanted to say we actually identified CJ before the last meeting and had invited CJ to join, but had been a mistake on the DSS side, and essentially we didn't get the right meeting link to CJ in time, so she wasn't able to actually join. And then Carol and Josie are also joining. We've been in conversation with DDS to find a few more folks, and I don't believe Josie was going to be able to join today, though I believe Carol was going to. And I want to take just a moment and ask if I do see, I believe CJ's on, just take 1 minute and say brief introductions, anything interesting to basically interest of joining this group in the conversation. So CJ, do you mind if I pass it to you if you're able to speak, and just to say, again, just do a brief intro for about 90 seconds or so. And CJ, if you're trying to talk, can't hear you at the moment. Not sure if you're able to get off mute. If not, can come back around. Not so. If you can, CJ, let us know. We'll happy to come back. And I don't think Carol or Josie are on at the moment, so we'll give them opportunity at the next meeting. But wanted to welcome at least them and acknowledge it. And we have a few folks who are subbing in. Just FYI, we've kind of hear about that, and so we've allowed for that kind of with kind of pre-approval. So there'll be a few other folks who are subbing in for others. If you want to go to the next slide, we'll keep going. Great. And so just in terms of the meeting schedule, so as a reminder, this is our 5th meeting. In April, we had our introductory and background meeting, May on primary care goals and strategies, and discuss some of the kind of pivoting kind of some of these conversations. In June, we discussed the primary care some primary care design features and also the prior work. So we had a bit of a scope discussion at that point. In our July meeting, our last meeting, was that listening session on addressing health-related social needs and community needs, as well as a little bit of data review. And then today, we're planning to review the primary care program examples, as briefly mentioned, and how they interface with health-related social needs. So we thought that would be a helpful bridge to this work, and also wanted to review and discuss some of the supplementary data as time allows. As a reminder for the group, the overarching goals for this work is with guidance from you and others, including obviously MAPOC, who ultimately will be bringing this back to as well for a lot of feedback, is that we're looking to improve the biopsychosocial well-being, health and well-being of our members, especially for our most historically disadvantaged, in a way that reduces inequities and racial disparities. And our next meeting is in September, and we'll be having an in-person extended meeting at that time. We'll set it up to be hybrid for those who are not able to attend, and we'll be sending out some further information in coming weeks, but that's going to be in Hartford. We're finalizing again some of those details, and we'll be looking more at that point to dive into more specifics on the features of the new primary care program and take some, and also just some time to connect together, since we haven't had a chance to meet in person or as a group. So I want to take a pause and see if there's any input at this time from this committee on the meeting schedule or any things we're planning on discussing as of yet. Polly, please.
Brad, just I don't know if it's a language clarification. In September, when you say design decisions, are we going to be teeing up what we would recommend from the program design with decisions to come later, or are you actually looking for decision making in the September meeting?
We're going to be, I think, teeing up some things that we'll need to discuss. I suspect it might be hard to finalize decisions in that meeting itself, but really trying to move towards like, here's what we've been discussing. Here's some specific items that we want to bring to all of you to kind of provide feedback and guidance on. And then obviously we'll want to take that back and then follow up in the future after that meeting. For those who have participated in the maternity bundle, which I know a few of you have worked, often we would present some either straw person or other recommendations, or also just discuss larger opportunities for what other states are doing, and then provide that input and then get all of your input. So kind of a little bit more in the weeds into some of these details. So today we'll be talking about kind of a little bit about health-related social needs, and then looking to bring probably some more specifics about what other programs are doing more broadly outside of just addressing those as part of that in-person meeting in September.
Okay.
So not necessarily decide at that point. I think that would be, but it's kind of informing more
getting into the actual things that will turn into the decisions or the recommendations.
Exactly.
Okay. Thank you for that.
Thanks for the clarification. Ellen.
Yeah, I brought this up before, and I just want to be sure this is still the case. We're not making decisions. I don't know that again, as we get further and further into this, and as I read more of the information that you're sending, I think that we're going to have disagreements about things, and probably have different, even teeing it up. I might be looking at different things than it looks like you're moving toward. And so I just want to be clear that we're not making the decision, and I have, the right to disagree with everybody. And that doesn't change, whatever happens afterwards. I don't have to forever shut my mouth. That there's an understanding that, there's a diversity of opinion, and that may still be the case after September or October or whenever.
Yeah, and thank you, Ellen, for clarifying. We don't expect everyone to be on the same page. That's just going to not be possible. And we are looking for, obviously, everyone's varying perspectives, and we very much appreciate that the various lenses you all bring are important, and we don't expect that there'll be a uniformity of agreement. And September is not our last meeting. We will continue to meet. This is just kind of for planning purposes that we want to start talking a little bit more in some of the weeds in terms of getting into some of the details about what program design may look like in some of those decisions. Acknowledging exactly what you're saying, Ellen, that we anticipate there's going to be disagreement amongst the group itself, amongst even how we approach it, I think, and I think that's understandable and also anticipated, and that's part of this process. Is obviously we do want to hear from the diverse group of people that are represented here, and so we are looking for that feedback. And Ellen, I would anticipate hearing from you on those things, and we just want to acknowledge that we don't expect you to sign off, or anyone to sign off and say this is what we all agree upon, because I don't think that's realistic.
Good, thank you.
Brad, I'll just flag, there's a question from Karen in the chat about the overall timeline for the committee. And I think we do have at least a sort of preliminary answer to that, which is to say that, as previously shared, we would be working towards a targeted new program launch date of January 2025. At this point, we've stepped back a little bit from sort of the showing the sort of broader timeline for this group in terms of the month-to-month plan for getting there, just in an effort to be a little more iterative and responsive to this group's, requests for how we move forward. And so we can bring back a sort of overall timeline, and then maybe we put that on our agenda for September.
Okay.
Thank you.
I also see there's a question about the number of people. Well, first, let me step back a moment and address the issue that Ellen raised. This is a very diverse group, and everyone's voice will be heard here. So that's, and that applies across the board. We will not all agree, but I will be sure that everyone has an opportunity to weigh in, and that not one opinion is going to be stronger or more directive than another. That's the direction we're going in. Okay. Now, in terms of what we are doing in terms of, was there a question about space? I'm not sure Angela, I see that you asked that question about the help from the Phillips Health Ministry. You had a specific question about space?
Yes, if you're looking to accommodate an in-person meeting, just looking to see what your requirements are in case we are interested in hosting. I don't know where you all are looking.
Okay, thank you. We are looking at a few spaces. There are some here in Hartford and some of our state buildings that will and are large enough and have enough parking, because that's always a challenge. We can hold the numbers of people that we need to hold, but parking is always a challenge. But if you're interested in hosting, that would be wonderful. If we could get some information from you, then we can add that to the list of the places that we're considering, because we need to make a decision fairly quickly. We wanted a space that was also more centrally located, so that not everybody has to do a lot of driving either.
And Commissioner, I was just going to say, we actually have confirmation on the 450 Columbus Boulevard site location, but though obviously we could consider an alternative, but it is reserved in Hartford. So just a FYI.
All right, but
and also I'd like to say, if you want to also have a central location, certainly more than welcome to come and meet also in Middletown at the Cross
Church. All right. Would you mind sending Brad those locations? That would be great. We just wanted to confirm something quickly so that we didn't run out of, because the big spaces go quickly in the state buildings. But thank you so much for making that offer.
Agreed.
Yes, that would be great.
Any other comments on this or related items? Seeing none, we'll head to our goals for today. So to be responsive to this committee's request for additional data and give community members an opportunity to discuss priority data topics, and then discuss state and federal primary care programs that could inform DSS's primary care program design process and support the transition to more targeted discussions about the role of primary care within a broader system of care that recognizes and addresses health-related social needs. And so we'll split those a little bit, just since we're going to be having a, we're going to talk first about the program design, and then we'll talk about the data towards the end today. I think next slide. And so one other thing we wanted to bring to this committee, which some of you may be already well aware of, is an update on Public Act 23-171, which was signed, passed by the legislators, signed by the governor this summer. And very much in light of our discussion from our last meeting and feedback from all of you, this seemed really especially important just to highlight. And so I'm just going to kind of highlight a few of these pieces at the top. Part of this in the act, DSS will work with the Office of Health Strategy, the Office of Policy and Management, and other agencies and stakeholders to develop a strategy that improves healthcare outcomes, community health, and health equity to support Husky Health members. And so there's an excerpt here, and I'll just note that a few of them: improving healthcare access and outcomes, increased adoption of interventions to support improved access to preventive care services, identify and address social, economic, and environmental drivers of health to address long-term preventive health and healthcare outcomes, explore innovative financing reforms, improve collaboration coordination among healthcare providers and cross-sector community partners, and improve Medicaid reimbursement performance to achieve a sustainable healthcare delivery system. And not later than January 1, 2025, the Commissioner of Social Services will submit recommendations for reform to MAPOC. And so I think very much related to some of the conversations we've been having in this group, and that, I think as we see this very much related to some of the work that we're discussing here in terms of primary care payment reform, that these are processes that can occur in parallel. And that we see primary care as a foundational part of our healthcare system, but acknowledging that it's definitely a small part of addressing, or a smaller part of addressing, larger social determinants of health and health-related social needs. So the impact of improving primary care and trying to improve our system is important, but it won't be the only solution. And we'll need to continue to think about opportunities to improve the broader health and well-being of Husky Health members in Connecticut more broadly. So just wanted to make sure that we were all aware of this and discuss and make sure that in light of our prior discussions, that this was on the forefront and will be something that we are working on as we are also working on primary care payment reform. Let me pause to see if there's any questions about this or how this relates in any way.
I have a quick question, if you don't mind. Understanding the requirements and the thinking around primary care, I wonder where behavioral health care fits in to the conversation, or has it ever? For a couple of reasons. One is, a lot of folks see the behavioral health people a lot more than they do primary care, and just wondering where that stands.
I think we've kind of tried to create a very large tent for this conversation to say that primary care, it can be very comprehensive, and historically maybe very narrow, but I think increasingly is being thought of as more fully integrated by behavioral health services. And for some people, that means they see behavioral health more than primary care, and that makes more sense for them, obviously, depending on individual needs. But I think as part of this work, we want to think about behavioral health integration, as well as dental integration, which came up early on and as part of our conversation. So think holistically about what does that look like? What could it look like? And I think that is part of this broader conversation. If we're talking about the biopsychosocial well-being of people, if we ignore any of those things, then we're really, not being comprehensive in how we're considering it. So just to say, I think definitely part of the conversation, including other facets maybe that we historically haven't considered as part of primary care. I know that's becoming more common than it used to be, but it's still maybe not across the board mainstream where when we think about primary care, we think about behavioral health services.
Well, in the FQHC system, certainly it's more integrated. It's just not funding is not available on the other, the other systems. So that's just a thought.
Thank you. Ben?
Hi, thanks. I'm very pleased to see Public Act 23-171 up here. We're at Stanford Health, we're very excited about the opportunities that this presents. And I was wondering if you could say more about how you see this work and the work that we'll be doing in the future around these new requirements working together. And the answer may be we're still figuring that out, but we recognize that they're related to each other, and that's fine too. I'm curious to hear. I do think there's a ton of interrelatedness between the two.
Thanks, Ben. And just I'll happy to take first stab at it, and Commissioner, you're welcome to jump in as well. But just to say, yes, very much related. And I think we are still figuring out exactly how this will work. A lot of this will be in collaboration with others. And so I think we don't know exactly what we know. There's opportunities to improve the health and well-being of our members more broadly. And exactly what that looks like strategically, I think will take a lot of input from outside entities to help inform that. And I think, as the commissioner already alluded to, we are going to be looking for that as part of this process. What that looks like exactly yet to be determined. But we do, primary care does fit within this framework to a degree, understanding that it's not the solution to all of this. I think try to be real explicit that it can't be. It just doesn't make sense. But it can be a part of it. It could be a piece where it can help enable it, but it can't be the solution. It just doesn't make sense. Commissioner, I don't know if there's anything else you'd like to add.
Okay, thank you, Ben. Thank you. This section of this Public Act was also developed in partnership with the Connecticut Hospital Association and other key healthcare delivery partners. So the idea is to, this is an excerpt of the act, is to bring many people to the table to have the discussion about how we can improve healthcare access and outcomes. Actually, there were a number of commissioners actually met with the governor yesterday to talk to him about a more integrated approach to addressing the concerns that people have in our communities, and really the great need that they have that isn't necessarily addressed specifically in a healthcare provider's office. So for example, we explained to him that one of the most significant barriers that people are facing is a lack of housing, right? Stable housing, affordable housing, and housing that is in areas where they can access the things that are really important to them, like good schools for their kids and being able to get to healthcare and to jobs that pay well. So all of these things are really critical. So we really were explaining to the governor why housing is so important. We also know that in some other parts of the country, California as an example, we have some hospitals and other large health care organizations who have actually invested in their communities by leveraging Medicaid and building housing. So if there's a way for us to think creatively, like that organization did, about ways that large organizations and small can do more to do things like promote high quality care and integration of primary care and help to solve some of the larger social and economic issues that we have, that was really the purpose of this section from Public Act 23-171. So it isn't just one particular segment. It isn't just one particular organization. It really is meant to be a holistic approach and to look at other states and see what they've been doing that we might want to adopt. And we may come up with our own innovative ideas to address some of the concerns we know, to Alice's point, that can really help us to move the needle for the people that we support. So thank you, Brett. That's what I wanted to add.
Thanks, Commissioner. Ellen?
Yeah, I'm probably jumping ahead. Hopefully I'm jumping ahead, but I hope we have, and I know we talked about social determinants before, but, and I said I was doing a lot of research on this and I had not looked into it as much as I should, but there's a lot of new research and kind of depressing research around primary care and connecting to social determinants and how it's maybe not the most effective way to do it. And I think, you know, and I've heard about hospitals investing in housing, you know, community gardens, and that's great. But I worry about one-offs like that because the medical system is not really efficient with resources. And I worry that that's, you know, that community members might choose a different solution for housing than a hospital would. And so I just think that's a longer conversation we need to have at some point. But when I hear about great ideas like that, I get my, you know, red flags go up for me.
Okay. Well, I'm not suggesting that it is I'm not placing a judgment on the idea. All I'm saying is that there is lots of opportunity to talk about all of these ideas and that those conversations are going to happen.
Okay.
I thought I saw someone else's hand up.
Yeah, I thought so. Someone may have put it down.
Okay.
And I think there will be time for some more conversation as well on this. So just to say, appreciate the comments and and also just the thoughtfulness here. There's, like as Commissioner mentioned, there's going to be more time for more opportunity given this legislation for conversation in the future. Oh, actually, I think. Carol. Actually, I see Carol on. Carol, I think. Apologies.
I wasn't sure, Carol, if you were applauding or your hand was up, or I wasn't really sure what was going on. So, yeah.
No. First of all, I didn't realize that there was reimbursement for Medicaid, unless I'm misunderstanding that.
You mean for housing? Sorry, and actually, Carol's one of our new members, and I think Carol may have had an issue with getting you the correct link as well, but I think it looks like you're here. We tried to do some brief intros earlier just there's a few new folks. And I don't know if you want to take 60 seconds to say hello and introduce yourself, and feel free to do that.
Hi, everybody. My name's Carol Grabby, and I'm the self-advocate coordinator that works here in the Wallingford office. And I'm new to this committee.
Welcome. It's good to have you.
Thank you.
Yeah, so again, these are really broad, sweeping ideas that were meant to be more comprehensive in their scope so that we could have more expansive conversations about reimbursement. So this, you know, the idea about improving Medicaid reimbursement and performance is very expansive, right? It could mean more hospital reimbursement. It could mean reimbursement in all of the areas where we already provide reimbursement, but it also doesn't preclude looking at other places where we might be able to leverage Medicaid match to meet needs that we haven't yet identified, because we really haven't sat down as a group and really talked about those. And one of the examples, again, I'll talk about California, you know, who's already pursuing justice involved waiver as an example. It's not necessarily in the wheelhouse of what we're talking about today, but they have identified a need that helps to address recidivism in that state, and they are looking to leverage Medicaid as what they believe will be a very effective tool in helping people who are returning to their society, to their communities, and having them be better prepared to re-enter their lives when they do. So that's really what we're talking about. It's really an opportunity for us to really just think about and identify with lots of partners at the table, what are really some of the really critical issues we're trying to address, and where can Medicaid play a role in that. And if you look at number 5, we're really looking to improve the collaboration and coordinator around not just healthcare providers, but also other community providers and strong community partners. What's not in here are things like, well, can we see a more enhanced and substantial role that community health workers might be able to play to address the needs that people have in communities? We haven't really had those conversations at length in this context. So those are the kinds of things that we're talking about.
So I have quite a few questions.
Okay.
I'm wondering if the reimbursement for Medicaid also includes doctor's appointments, like regular doctor's appointments that you might.
Yeah,
go to.
for the doctors for the doctors that do see patients that are on Medicaid, it does include that. But one of the concerns that doctors and other healthcare providers have raised is that the rate is not sufficient for the people that they're seeing. And that would be part of what we would be addressing here in the work we're doing here, and also in some of the work we would be doing with the Office of Policy Management and the Office of Healthcare Strategy.
So,
Okay, and we were talking, I just had gotten in and I heard something about housing. So is Medicaid what does that have to do with the housing part?
Well, I think I don't want to take up all of Brad's meeting, so
No.
So,
It's just, I just
what I
wanna
was
make sure I'm
so I was just speaking of an example of how some other states have leveraged Medicaid reimbursement and Medicaid support in order to build housing. But Ellen makes a good point. Sometimes the housing that hospitals and other organizations might build might not necessarily meet the needs of the community. But I don't know enough about what they've done in order to know whether or not that is in fact the case. But it's an interesting model that we would be exploring along with many other things in what we would be doing in the work of this under this public act. So,
Okay.
And Carol, I'm happy to set aside some time and we can walk through the rest of it. I know it's kind of hard to sort of jump in near the end, but I'm happy to have more conversation with you.
and
Thank
actually,
you. Who am I speaking with?
I'm Andrea Barton-Reeves. I'm the Commissioner for the Department of Social Services.
Oh, okay. Thank you.
You're
Thank
welcome.
you.
You're
You're the
welcome.
one I got the email from, Andrea Reed.
Yes, I'm the
Thank
one that
you.
sent the email. You're quite welcome.
Thank you, Andrea.
and actually, I think Commissioner and Carol, a little bit related is actually the next slide where we, at the last session, did hear about a few of these topics that I think are very much related to this. And I'll just highlight it partially to say, we try to pull out some key themes from the last session. One is we want to make sure we heard from you all that, and this slide is what I'll talk through, but there's two other slides where we tried to provide a little bit more detail. But the four major themes that we thought we heard were developing and expanding social determinants of health and health-related social needs initiatives, including multi-agency partnerships and integrating resources. So I think responsive to some of the comments that were being made.
I'm
There's
sorry. Can you repeat solely what these acronyms stand for, please?
Yes, and actually, Carol, I might invite, just because of our limited time, I'm happy, may have seen my email, happy to connect maybe afterwards or just to go through, because I know we haven't had a chance to catch up.
Thank you so much,
Would
Brad.
be very happy
Thank you.
to do that. So
Yeah.
I think
Thank
Jerry
you.
may be reaching out to schedule some time to help.
That would be great.
Brad, if you don't mind, I'm just going to say, so for we have 3 new members, and I know there's a lot to catch up on. Brad and I actually are putting together an agenda and a training for you so that we can do things like explain the acronyms, bring you up to speed on where we are. Yeah, so it'll be really, we know it's hard to sort of jump in. So we're working on that, and we'll schedule time that's convenient for you and walk through everything for you. Absolutely.
Thank you. Very helpful.
You're welcome.
Thank you.
Very welcome.
Social determinants of health, health-related screening, referral outreach. So on that, really building the capacity of community-based organizations and community health workers in communities. I think that was really clear last time in terms of delivery system components. So thinking about a broader community-wide health-related social needs strategy, so very much related to the public act we just discussed and some of the comments that were made, and thinking about regional hubs of coordination, and also thinking more upstream, and then financing and accountability. So thinking about supporting existing CBO collaborations and promoting whole person financing and accountability. So breaking down those barriers of finance between various programs and potential agencies. So this is what we are trying to highlight from what we heard from you last time. And so we just want to take a moment, one, to make sure we broadly heard that correctly, understanding there's going to be disagreement amongst the group about exactly what the focus should be. But we know it's important, one, hear you that can inform some of the work that will be going on in the future, as we just discussed around the new public act, but also as part of this work, and how does primary care reform fit into this, to this broader work that DSS will be considering moving forward. So let me just pause, see if there's any comments or questions. And then I think next we'll get into a little bit of the those are the two slides for reference if helpful. So we can pass through them, I think, Olivia, for time's sake. But if you all would like to review, if you have any comments or questions or thoughts, or if we missed something really important, please feel free to. And Commissioner, go ahead.
Thank you, Brad. What I've noticed is I've been attending the meetings that the themes around, these are all the key things, no question, but there still seems to be this underlying theme that somehow we have to get to those social determinants of health if we're going to create a system that we think will provide the greatest degree of support and good healthcare outcomes for people. The challenge we have is, how do we do that without this kind of getting so broad and away from us and not getting to something that we think will work? So what I'd like to do, I think, especially during our in-person meeting, is to really set aside some time to have a more in-depth discussion about that. I know we've done that in some of our online meetings, but it's a hard discussion to have online. I think it's a better discussion for us to have in person, and so that we can really figure out whether or not there is something that we can do. Can we do something in part? Can we do something in whole? Do we want to focus on one particular social determinant? And can that and should that be part of the model that we're creating? Because I see it continuing to emerge as a theme. It's extraordinarily important, and it might be a question that is so big that we would not be able to answer it in the context of the work that we're doing. But I would like to have a more substantive discussion about it. Karen, I see that your hand is up.
Yeah, I just wanted to say I agree with you that it's a big conversation and that kind of focus is really necessary to figuring out what the goals are. I just would want to know how Medicaid enrollees are being leveraged to choose those priorities rather than just this group, which is largely made up of folks who are professionals and one.
Yeah. So that's a great question, Karen. So we're not looking to make decisions about it. What I'm looking is just to hear the input and the feedback. And then I think together we can make a decision about, okay, well, you know what, we're talking about it in this room. And I think, if Guy were here, Guy, Brad, and Bill, they will always tell you, the question I'm always asking is, who's in the room? Who are we making the decisions? So it's a starting point for the conversation because you will all be in the room. But we're not saying that we're going to make the final decision about, who's going to be without the voices of the people who will be impacted by that. So you may say from your own observations, I think as a healthcare provider that we need to really focus on housing, or I think, the transportation is the greatest barrier. And that may be from our own experiences, but is that really true? So that you need a next step in order to be able to really test that and prove it, right? And with the people who are actually receiving the support. So it's not an inclusive, it's not, I should say it a different way. It is not an exclusive process. What I'm suggesting is let's finally dig deeply and have that conversation because you've been asking for it for a long time and I'm hearing it. So I'm saying, let's just start and then we can decide as a group, all right, so where do we go from there? Alice?
Thank you, Commissioner. Very quickly, I've been looking over the key themes and also reviewing all of the data that we've been given. Thank you. Really interesting. Racial equity is a gigantic issue from what we're seeing in the PCMH and PCMH plus. And so I know you're saying, let's think about focusing on one social determinant that might be a play, but I also think that might be a very important area to look at, in particular our BIPOC community and what would work for them. The Behavioral Health Oversight Council does have a BIPOC DEI committee. We could certainly take this up as one of the conversations, but I do think there should be a real focus on that from what I'm seeing in some of the data. So thank you.
Yeah, thank you, Alice. Yeah. And again, I want to say that I used transportation or just focusing on one as an example of where our discussion might go. An agreement that we might land on, it might be, we want to do something in each of these areas because we really think that landscape that is as critical as just focusing on one. And we may say we don't have enough resources to do that. So what should we do? I'm just suggesting that we use some of our time to actually have that discussion. And you're right, racial equity is an enormous challenge, that I have personally experienced. I know that to be the case. So it absolutely has to be part of the discussion that we have. Okay.
Sure. Thanks,
Dr.
Alice.
Dr. Richards.
Yes, just gonna, I think for time's sake, was gonna move us along to the kind of review and discussion about I think very much related to this conversation is like, but what is the role that, as we're thinking about our existing primary care programs and learning from other programs, how do we take this and start maybe building something or thinking about what could be built in the future to address some of these, to use primary care as a small lever and addressing some of these health-related social needs. So I'll pass it over to Olivia in a moment, but really just thinking about the core elements of what primary care programs launched that are already doing this at the state and federal level, and then thinking about what the role that these programs are playing in addressing these needs within these programs. So, and we'll ask for your feedback on them. So there are design features that you think are interesting that could make sense. And again, the broader role that primary care can play in addressing these needs. So Olivia, let me pass it over to you.
Great, thanks, Brad. So as Brad said, we'll start with just a little bit of sort of broad orientation to what some of these primary care programs are doing sort of overall, just so we're all sort of grounded in a similar understanding on that point, and then talk a little bit more specifically about the answers, these programs at least have to, what role primary care can play in a broader system of care that's oriented to addressing health-related social needs. So we're going to start by taking a look just at a couple of the federal programs, recognizing that Medicaid is a partnership program, and so understanding, what the federal government is doing in terms of primary care, helps to illuminate where CMS's priorities are. And so just at the highest level, worth noting that, over the past 10 years, the CMS Innovation Center has launched a sort of series of primary care program models. They started with comprehensive primary care, or CPC, that was followed by CPC Plus, and then more recently by Primary Care First. Those models have really been launched sort of in sequence as, essentially they're voluntary, multi-payer advanced primary care model demonstrations. They are operating in select states and in a growing number of states as you look across those three programs. It's also worth noting that CMMI has recently put out a new model. So Making Care Primary was just recently announced. That program has not yet launched. It will launch in July of next year. It's going to be a demonstration that's a little bit longer than is typical, so 10.5 years as opposed to the normal 5. It'll be in 8 states with a focus on aligning with the Medicaid programs in those states as well as with commercial payers. And so we thought that we would, start by just sort of taking a look at, what these programs are sort of trying to do, at the highest level. Of course, they're all, different to some extent in terms of how they're designed, the different program elements that they include. But they also share a lot of similarities. And so as we sort of step back and say, at the highest level, what are these primary care programs trying to do? What levers are they using? All of the federal primary care programs, are using what could be described as sort of 3 key levers, right? They're establishing care delivery requirements, which are really there to ensure that patients are receiving comprehensive, integrated, coordinated, person-centered primary care. They're recognizing that in order to be able to deliver that kind of care, primary care providers need to be paid appropriately and in a way that enables them to deliver that kind of comprehensive care. And so they're making changes to the payment models, right, that they use to reimburse primary care providers for their services. And then, the final dimension you'll see is performance measurement. They're establishing performance measurement programs to monitor and hold providers accountable for improving quality and for improving outcomes for the members that they serve. And again, while all the programs are to some extent, different in terms of their unique structures and what they're doing, across these 3 dimensions, they share a lot of commonality, right? So From a care delivery perspective, they're implementing chronic and episodic care management programs. They're using data and team-based care to proactively identify patient needs and really focusing on identifying specialty, behavioral health, and health-related social needs, and assisting patients with navigating and coordinating resources to meet those needs. From a payment model perspective, they're all recognizing that historically primary care practices have not been reimbursed necessarily for some of the augmented staffing, right? The additional staff roles, the community health workers that are being incorporated in this team-based care model, and for some of the screening and referral and coordination activities that primary care practices are, being asked to do under these models. And so they're adding funding for care management, and they're transitioning in different ways across the different programs from a fee-for-service payment model to a population-based payment model that gives providers more flexibility in how they deliver care and how they meet member needs, and enables them really to deliver more of that, sort of enhanced array of comprehensive services that you see articulated in that care delivery section. And then from a performance measurement perspective, right, they all have a defined quality measure slate, a scoring methodology, incentive payments for meeting certain goals or penalties. And those are tied to a range of measures, quality, patient experience, utilization, and in some cases, cost metrics. And then they all have reporting requirements and data collection strategies that support ongoing monitoring and evaluation in terms of, how the program is working, what it's accomplishing. And so I think as we, I'll just say, there are more details on sort of what each of the programs is doing within those dimensions. I'm not going to walk through all of those today. They're here if you want to refer to them, at a high level. When you get into the details on any one of these programs, right, there's a lot there. But I think if we keep in mind as we start talking about some of the the program design elements and features that we might think about exploring, down the road, it's instructive, I think, to think of these sort of three dimensions and what those federal primary care programs, are doing. In some ways, they are illustrative in terms of what could be done in any one of those areas. I want to talk a little bit, so I'll pivot just in the interest of time and keep us moving towards, the health-related social needs component of each of these programs. And, I think it's worth noting that all of these programs do have an answer, right, to what role is primary care going to play in addressing health-related social needs? Health-related social needs and equity and social determinants of health are a part of every one of these programs. And I'm putting up just an example here from the most recent program, the Making Care Primary program that CMS has launched. And I think it's, in some ways instructive of the vision CMS at least has for, what role primary care is going to play in this broader system of care. And so if you look at the, at the left-hand side of the page, you'll see what they're illustrating as sort of the current state of care, a disjointed system where the different pieces of, a patient's care team are sort of talking to maybe one or two other parties, but that there's a lack of sort of connection, right, across all of those dimensions, across all of those different people that make up a patient's care team. And so in this model, at least, what they're illustrating is that primary care is really going to play a role in integrating that system of care, in helping patients to navigate their healthcare through some more care coordination. And you'll see that that's inclusive of health-related social needs, right? So if you look at the orange boxes here, which relate more to the sort of social needs, that the social worker and the community health worker and the social support services are a part of that sort of integrated system. And primary care is really playing the role of helping to integrate that system, helping to enhance the coordination between the different pieces of a person's care team. As we think about what that actually means, sort of in detail, what the function of the primary care practice is, I think, we'll return just to those sort of three dimensions, and we can take a quick look at sort of what each of those three federal programs, so CPC Plus in the first column, Primary Care First. You'll recall those are the sort of older programs, and Making Care Primary, the more recent program, what they want primary care practices to do, what they imagine the function or the role of the practice is in addressing health-related social needs. And so from a care delivery perspective, the big thing that's shared across all of those programs is a requirement that practices are screening for health-related social needs. So they're assessing their patients' needs. In the prior programs, the practices were required to have an inventory of services and supports in the community that they could refer patients who had positive screens to. The more recent program you'll see takes that a little further. It says, well, actually practices are going to develop and implement referral workflows. So you're not just going to get the name of a local food bank, you're going to get a referral and some coordination from your primary care team around getting you there and making sure that you actually have your need met. There's also a sort of focus on partnering with social service providers in some of the programs that gets more elaborated in the most recent program. So under Making Care Primary, practices are going to have to actually, partner with some community-based organizations to help meet their patients' sort of most prominent health-related social needs. And in the more recent program, you'll also see the addition of a requirement to utilize community health workers or other equivalent professionals with shared lived experience to help deliver care to the sort of highest need patients. And so this is what, at least the federal primary care programs kind of imagine, right, primary care is doing to help identify and address health-related social needs. It's worth saying, right, they also have ideas about what's going to enable the practice to do that. So they're making changes in the payment model, they're implementing performance measurement standards that are related to health-related social needs. From a payment perspective, again, they're adding funding for staff like community health workers and some of these functions that primary care has not necessarily typically played, right, in terms of the level of coordination and screening that they're expecting. And they're transitioning to that population-based payment to provide some more flexibility in care delivery and to really enable practices to provide those services. And then from a performance measurement perspective, the most recent program you'll see goes a little further than the prior programs in terms of what it expects for accountability of practices in actually doing those things, right? Just to say that it adds a performance incentive measure that's tied to health-related social needs screening, and that it also anticipates the collection of some of that HRSN data to help evaluate health disparities in the communities that these practices are serving. I want to turn it to you all soon, but just before we get there, one more thing just to acknowledge, which is to say, of course, these are all federal programs. They're instructive in terms of where CMS's priorities are, but I think it bears mentioning that this is also something that is happening at the state level. So there are state Medicaid programs who are exploring very similar models, right? And answering that, also seeking to answer that question, what role will primary care play in this broader system of care that's more oriented towards addressing health-related social needs? And so I'll just quickly provide, you'll see here the Massachusetts example, neighboring state. So this is the Mass Health Primary Care Accountable Care Organization HRSN strategy. And you'll see that it's, in many ways has a lot of similar features in terms of screening, referral, coordination, integration of team-based staff, a very similar sort of approach to the payment model in terms of additional funding for care management and that transition to population-based payment. And again, the performance measurement and collection of data to help measure disparities. I see hands already, so let me stop. Ben, go ahead.
Thank you. This is a really great overview, and these are super complicated programs, and so to describe them as quickly and as comprehensively as you did is very impressive. So thank you for that. I think the federal programs, especially Making Care Primary, have a lot of promise, and recognizing that we can't just do this additional work on the backs of existing payments and existing staff. That's one of the things that makes Making Care Primary in particular very exciting. I think pointing to state level models is also important because we're talking about Medicaid. and states have really been very innovative around Medicaid. And to the point that we were talking about before about the role of primary care as a part of broader system transformation, there are a couple of states that I would encourage us to learn more about. One is Oregon, which has taken a regional approach and really thought about the role of primary care within regional transformation. And then there's been some interesting work, not only in Oregon, but also North Carolina and New York around social determinant of health networks. So I think that as we go to have that deeper conversation, learning more about those states could be very helpful in addition to the ones you've got on the following slide. So thank you so much.
Thanks, and appreciate those suggestions for further examples. I know I think started talking about at least Oregon and North Carolina in our last meeting. So heartily agree as we continue this conversation, thinking about the role of primary care within those programs makes a lot of sense. Ellen, I think you're next.
Yeah, this is where we're going to start to disagree. I think it's also very important to point out that CPC Plus has lost about $500 billion overspending, has underperformed, let's say that, in terms of improving quality. There have been a few small places where it's improved, but by and large, there's been no improvement in quality. On the upside, there's been no decrease in quality, at least for the things that they were measuring. I think CMMI has had over 50 programs. Most of them have failed. Only a few have been chosen for scaling up, and none of the primary care ones have been. They keep tweaking the incentives. Let's go to 50% upside and 10% downside, and maybe that'll change everything. They're not really looking at underneath the hood at what kinds of things really at the base level we need to do to improve access, things like loan repayments, creating more residency slots, giving broader access, a bigger scope of practice for nurse practitioners and PAs, things about team-based care that could be done better. So they're not really getting underneath it. They're sort of, putting requirements out there around screening and then changing the payment models. And it's not working. So I think we should look at these with a grain of salt, really. I agree we should look at other states, and I'm in the middle of doing that, so I'm not ready to, say what I've found or what other recommendations are the advocates might be making for what we should do to think about primary care. But we really have to look at those options closer to the ground and not just change, the way we pay for things and assume that everything's going to flow down from that in a good way. Also for screenings for social determinants of health, yes, they're requiring, but when you look at that, the evidence around that, and that's true in some of these state programs as well, it is not working really well. This call and refer is just not getting people into care. Calling and referring somebody to a wait list just doesn't do them any good. And I think we need that if we want to pay for those other things like community health workers, like, coordinating transportation and care, I think we should pay for it. We have to look at that as an option as well, as aside from just give them more money and hope for the best. I think partnerships with community partners is really important, but to my point before, that letting large health systems make those decisions doesn't necessarily mean it's efficient, and it doesn't necessarily mean that it fits with the values of what that community might want. So I think this is an interesting way of choosing to present the options, but I would have given a very different presentation, I guess, I'll stop there because I just have too much to say.
Yeah, Ellen, I recognize this is a point, as you often remind us on, which we might disagree. So I'll take the opportunity just gently to say, I think it's fair to say that, it is true that CPCU did not meet the criteria to be, scaled up, and that there were certain things, in terms of expenditures that perhaps, CMMI identified that they, spent more than they saved. But I do want to just, make sure that I think when we characterize that program as a complete failure, it's not really aligned with the evidence, right? We can debate, and interpret the evidence in different ways. I think we have actually in the back here, I'll just flip to it quickly, at least a brief summary of the evaluation results for CPC Plus, which is the program that you're speaking about. And that program did demonstrate reduced ED visits. It did demonstrate reduced hospitalizations. It did lead to improvement in some of the quality of care measures. And so, while that program was, perhaps there were things that needed to change. And I think this is actually very much right in line with the work of CMMI, which is to say, not all of the programs are going to succeed outright. And exactly what they've done is to iterate on these programs based on the evidence, based on the learnings, to try to get, closer to something that does work. So I just want to be careful when we're characterizing these programs as, sort of complete failures, that we do, actually bring in the evidence to which you're referring to and say, I'm not sure I would say looking at this that it's true that this, program outright failed. It had some successes, and there were some lessons learned, and, it led to the next iteration of the program, which, attempted to sort of improve upon that. So, it's an iterative process. I just want to push back a little bit on that characterization, as we look at some of this evidence, but heartily agree that, it's important to look at the evidence and that we should be doing that, as part of this design process. And so we'll try to continue to bring in that evidence and those lessons learned as we move forward.
Just to respond, we're going to have to agree to disagree today. I will be like putting something out, and, I think we can respond, and maybe there's room in the middle, and every failure has some sort of, like, we won't try that again. So you still learn things, even if something didn't achieve its goals. But I do think that, we should be looking at other options besides just what the feds are looking at. I think that's really important. And it's not so much what's here and, that I have disagreements with it, but also what isn't here. And that's, I guess, more of a concern.
Understood. Yeah, appreciate that clarification.
Do you have something specific that you'd like to propose?
That to me, yeah. Trust me, we will. Yes. But I'm not prepared to bring it out just right now. We will have. It has to go through a lot of advocates, and it's still percolating up from the literature, and then it has to go through a lot of advocates before I'm comfortable suggesting it. And I understood that there was more time in the timeline, that I didn't have to have that for today.
I wasn't asking for this very moment. You'd mentioned that you had some other ideas, so I was asking what they were. But if you need more time, I completely understand.
Yes, they are coming. Promise.
Okay.
I think Karen.
Yes, I wanted to just mention a couple of things about the data that Olivia just shared. But before I do that, I would just urge Ellen and others to please be specific about who you're speaking on behalf of. When you say the advocates, I want to make it very clear that you don't represent a number of advocates that we work with, and that we often disagree with those points. So I just want to be clear that that is not a representation of all advocates in the state of Connecticut. I also just wanted to point out that a lot of what has come out of CMS has been Medicare focused. And so to Dr. Kroll's point, doesn't necessarily touch on pediatrics and also several other populations that are not centered in Medicare. And similar to some of the other work in other states, it's predominantly focused on very high need members. And there is an opportunity and there is evidence from other states on programs that are more focused on primary prevention. And And I think it's important to think about that, to think about what other states are doing, and specifically to think about the ways that other states are building infrastructure so that we can do some of these health-related social needs interventions in a way that works in a state without managed care, right? I think what has been such a barrier in Connecticut has been that lack of infrastructure, and that's really central to tying all of those points together. And there are several models for that. And regional accountability is one of them that we certainly would support. But I just wanted to point out that I think, that the evidence from those programs is promising, and we need to think about the fact that they don't cover all populations and that they don't necessarily address the way that Medicaid works in Connecticut.
Thanks, Ellen. And I think I'll just take a quick second to say, I think one of the points of some of this work is like, it's going to be difficult to address all the needs for everyone, I think, and as David pointed out, is like pediatrics has often been left out. There's been a fair amount written that we need to be thinking about pediatrics probably quite differently, understandably. But I think there's also challenges with building a model that can do everything for everyone. And so this may be something that we think of as iterations where, one of the other pieces that I think was alluded to is the maternity bundle that we're looking to launch, which, in some ways is a subset of a different program that's focused on a very particular population. And that may be something that's necessary as part of this process, or a future process is thinking about how do we design programs for particular needs of particular individuals or just a different population. Which I think is important for us to consider as well, but that may be outside of the scope of this initial work, but I think this is part of that conversation. I think Carol? Oh, Carol, you're on mute.
When it says design elements, are we talking about like the literature, like for individuals, where it usually will say consumers or, clients, where individuals? That's what I've always had a problem with. So is that what we're talking about? Because if it is, that would be a great change with the forms for DSS.
Yeah, Carol, that's an excellent question. I don't think we've gotten that far yet, but you're right. And I'm actually going to make a note about that and think about that. And I think that's what Karen was trying to get to as well. And I think David, to a certain extent, is be more inclusive and transparent about the information and how it's shared. I think in this instance, though, we're talking about other models that we've seen or things that we have always wished were part of a care delivery that we'd like to just talk about a bit more. But your point about the care delivery model is whether or not people understand what kind of care they're getting is an extremely important part of that. So thank you for raising them. I'm actually going to make a note about that. Because I think that's critical. We're seeing it from delivering the care, right? And the perspective that you're bringing is the person who's receiving the care. And what does that look like?
Thank you.
Thank you. No, thank you. Thank you for that.
And might just take a quick note to say, like, one of the, I think, opportunities that exists is doing a better job of soliciting input from individuals, whether on patient-reported or member-focused or person-reported outcome or experience measures to drive some of these changes in payment. There's some challenges with operationalizing it, but I think the opportunity to better get the perspective of individuals who are receiving it and what's important to them, and if they're getting the care that they want, to help drive the impact on payment is a huge opportunity for the future of care, and trying to make sure we align between providers and people receiving that care. So just make a plug for that opportunity. Olivia, I think we have hit some of the discussion here. I don't know if we want to, seeing no other hands, I don't know if we want to get a little bit into the data as well.
Yeah, that sounds good. Given we have 20 minutes left, so we'll do what we can with those 20 minutes in terms of topic 2, and I'll acknowledge that we do, as Brad said at the outset, we do have a supplementary meeting, right, scheduled for the 24th of August that will be recorded and streamed for those who can't make it. So recognizing we will only get through, so much in the, remaining time we have in this meeting, recognize that there will be another opportunity to bring comments and questions and to get more into the data. So with that, I'll say, we did, so we organized the sort of priority ordering responses that we got from you all. Thank you to those of you who completed the survey. We've organized the topics, the sort of key topics in the data compendium in terms of the results of that survey, so that we can try to focus on, where you all wanted to focus the most. We'll say as we looked at sort of the top 4 items here, it felt like 1 and 3 were pretty well aligned, just to say they both had a sort of focus on the unattributed population, who they are, and then the cost and utilization profile of those members. And then 2 and 4 were pretty well aligned in terms of their focus on access, with some broader interest in other member experience measures. So an attempt to be somewhat curated about the discussion. What we've brought today, at least as a starting point, is first a sort of look at the unattributed, and then if we get to it, we'll talk a bit more about some of the access data. But to start with the unattributed, start at the highest level and say, what you're looking at here is just a sort of grounding in who the unattributed population is, as compared to the attributed population. So these are 2022 member months. You'll see the unattributed and the attributed by race, ethnicity, by age, and by sex. And if we start with the breakout by race, ethnicity at the top, I'll just highlight a couple of sort of observations and then welcome yours. It's worth noting that, a higher proportion of the unattributed members are in the unknown category, and that Hispanic members are more likely to be attributed to a provider than any other race ethnicity category. From an age perspective, we see that children are more likely to be attributed compared to adults. That's fairly expected given the more frequent delivery of pediatric care to children. So that's a common sort of phenomenon. And then we see that females are more likely to be attributed as compared to males from this data. And then I will show the next sort of piece of this and then pause for any other questions or comments about the sort of unattributed population. I think the other piece we have here around the unattributed members is a sort of cost and utilization profile breakdown. So what you'll see in the blue on the left-hand side is the cost and utilization for the unattributed population by service type. The orange in the middle is the attributed population by service type, and then the gray on the right-hand side is the variance between the two. And what you see, first and foremost is that, attributed members are utilizing a lot more preventive services than the unattributed members. So if we look at the rates of utilization between those two populations, you'll see the attributed population has a utilization rate that's about 4 times higher for FQHC services, about 2.5 times higher for physician services, and about twice as much for clinic services. And then something else you may notice as you look at the sort of differences between the attributed and unattributed is the sort of where the higher utilization and cost falls. So you'll see that there's higher utilization and cost amongst the unattributed for things like hospice care and Medicare crossover claims, which are for dual eligible members. And so part of what you're seeing there is the fact that Husky C and D members are more often unattributed as compared to Husky A and B members. And so some of the differences that you're, going to notice between the attributed and the unattributed population are those driven by who those people are. So the unattributed are more likely to be dual Medicare, Medicaid eligible members. And so we see some of that in the differences in cost and utilization between the two populations. So just wanted to flag that. So let me pause there and see if there are questions, comments, other observations that folks would add, at least relative to this sort of sampling of the unattributed data. Ellen.
No, I'm sorry, I can't find the slides myself, but in the unattributed, have you been able to figure out if some of them
No,
are,
hold on one second. Sorry, if you're not talking, could you mute? Sorry, there's a little background noise.
it's not,
Oh, I know it's okay. Sorry about that. Sorry, Alan.
the unattributed, when we've looked at it in the past, it seemed that they were people who have Medicaid as a secondary, and so that maybe they're getting their primary care from another insurer. Do you know if that's the case?
Sorry, I'm looking for the mute button. So it is the case for dual eligible members. We know that, right? That the duals who have both Medicare and Medicaid coverage are disproportionately represented in the unattributed population. And so that is one of the dynamics that you'll see within this data. I can't comment on other types of coverage, but for the dual eligibles who have both Medicare and Medicaid coverage, we do know that they are more often unattributed than the other segments.
I would say a lot of the adoptive kids through the DCF system who have secondary Medicaid are going to fall on the unattributed and untreated, actually, because the primary care private insurances that adoptive families have.
I actually do know that I mean, this is very old, but that the numbers of people with insurance, especially as the number of uninsured in Connecticut have gone down, but people have, not as great insurance, that is a challenge for the uninsured, but the people who have Medicaid as a secondary insurance. But I don't think we can assume that they are all not getting primary care. They're just not getting it through Medicaid.
And Ellen, that's fair to say in terms of the definition of attributed here, it is from the Medicaid perspective, right? It's Medicaid claims based. Carol, I see your hand.
Yeah, I just raised my hand because earlier I heard, I don't know if it was from the commissioner or not, but that transportation is a barrier for people with disabilities. Yes, that's true. Transportation has been a huge issue for people with disabilities. But now there's VEO, which is transportation for medical purposes for individuals. And there's also Encompass, which is also a program. And that's for individuals, who can be taken to work. So just thought I should share that.
Yeah, Carol, I saw that you had put that in the chat and actually made a note about it, because one of the things, I think we were mentioning it earlier when we were talking about what are the barriers to people getting access to healthcare, that transportation was one of them. And so maybe when we have our other conversation, I can ask you some more about what more can be done with that particular barrier to getting access to care, because we're responsible for VEO, as you know. Or what is it called, MTM now? But thank you for raising that. So I did make a note about it. I'd like to talk with you about it a bit more.
Okay, no problem. Thank you.
And I think, Polly, I saw your comment about how do we compare to other states. One of the challenges, I think, is sometimes the definition of unattributed, there is some variability about how that's defined to a degree. And I don't know if we have any. I will see if, I don't believe we have any. I know Larry is off. Larry McGraw, Dr. McGraw's off at the moment. I think it probably is quite challenging to compare state to state, and actually getting that data I don't believe we have access to it, but it's a very good question. Olivia, I don't know if you have anything you want to add to that.
No, I think that's right. I think that the definitions are typically tricky there, just because states, attribute people using different processes. And sometimes that's, assignment based, which totally changes the sort of landscape. So I'm, at least at this point, don't have a sort of comparable comparison on hand, but certainly we can look around and see if we might be able to find anything that's comparable to compare to.
Karen.
Yeah, so two quick questions. One is there a plan as part of this project to improve demographic data collection? Because we know that that's a big gap. And then the second would be, any thoughts around increasing the number of members who are attributed? Because in any value-based payment model, the lack of attribution of this large of a population is going to exclude these folks from anyone being accountable for outcomes for them.
I'll just at least note two quick things. So on the demographic data collection, I know there's definitely a statewide effort to improve that. I think as part of this work, I think that may slightly fall outside the scope of this, just given the challenges, but there is an interest. I know Susan Smith, who's not here, has been helping lead part of the process of thinking through better data collection. And that is something I think we were at DSS very, very interested in. Obviously, it's really important for us to know that so we can do a better job of understanding where our gaps in care are, especially if we're addressing inequities that we know exist already, but making sure that we have the data so we can appropriately measure and monitor. In terms of the second question, in terms of how do we actually do a better job of getting unattributed to attributed, or is that part of this? And I'll just say we have been working with CHNCT as some of their work to actually engage with unattributed members to try to help them become attributed. I think that definitely is part of this conversation. I know it's come up before, is where does that fit within this work? And so obviously that is really important that we get people who are not engaged in care, especially engaged in care, to do preventive services and screenings and all the things that we know can be really helpful and important. So just to say, yes, important. And Commissioner, I don't know if you want anything else on the demographic data collection piece, especially.
No, I did want to ask Ellen if she would later on email me a definition of disability. I don't know if we're working with the same one as we start to collect the data, because it's a very expansive category. So no, and right now, and I'm not sure what we can do with respect to the children either, but maybe there's something that can help us with that. That's all I wanted to add.
I'm happy to do that.
Okay. Thanks, Ellen.
Ben, I don't know if you want, I see you put a comment, I haven't had a chance to read. I don't know if you want to just say it to the group. We welcome that. Oh, you're on mute. Sorry.
Am I off mute? Can you hear me now? Yeah. So I'm gonna get a little data nerdy here for a second. So in a past life, I had the opportunity to see some similar analyses, and looking at unattributed versus attributed members and looking at spend can be really, really informative. And so there were two analyses that I remember seeing in the past that can be helpful. The first, just to help us think about the role of primary care and how primary care can contribute to higher quality and lower costs. So the first was just building off of Olivia's really good point that there's some population differences and demographic differences between the attributed and the unattributed. And by looking at like members to like members and doing similar analyses to what we see on the screen, that can sometimes demonstrate the value of connecting patients to primary care. The second thing that I was thinking is that sometimes unattributed members are less expensive because they're healthy. But what we see in a Medicaid population is that patients can be healthy, and then have a change in health status. And unattributed members oftentimes wind up using higher cost settings at that point because they're not connected into a preventative model. And so point in time analyses like this are informative, but doing longitudinal analyses on patients can be very helpful as well to demonstrate the value of primary care. So just two thoughts: if we have the ability to do additional analyses to inform our work.
Thanks, Ben. I know CHNCT and Larry, and again, Dr. Monroe is not on. They actually have done some looking across periods of time. And I don't think we have any of that included, but it's probably something we can send out. Olivia, I don't know if we've, I don't think we've included that in our packet.
We don't have that included at this point, but I know there is some of that exists in terms of longitudinal studies, so can follow up there. And on that point, just quickly, I'll say, David, you had a comment about pediatric members, so I'll plug for the data compendium. There is the same data that you see here for some different demographic breakouts, including children versus adults. So we weren't able to bring all of that in here, but there is some of that in the Excel file that you all received.
And I see Josh will probably be our last question comment.
Sorry, I just want to follow up on what Ben said in some of the other conversation, because it sounds like there may be an apples and oranges scenario here with this data comparison. And I just want to highlight, and I know it's an entirely different population, but for the state employee plan, when we run attributed versus non-attributed members, our unattributed population has higher utilization numbers, PM, than our attributed population. But we don't have, right, they're pretty similar, right, in terms of demographics, age, and we don't have, other coverage issues, right? Ours is always prime coverage. And so I just did want to highlight that there may be, some uniqueness to these populations that may make these numbers not terribly comparable.
Thanks, Josh. I think we are getting close to 12:30 and our time is close. If there's no further comments or questions, I think we will, just as a reminder, we will be having another talking more about data related to this and that data compendium on the 24th coming up. Again, I know not everyone can make it, but for those who are available, we'll be spending some time there and trying to curate some of the data, because I know even then we're not going to have time to go through all of it. We've appreciate Olivia and the CHNCT team, as well as others, in pulling together a lot of that data for your review, hopefully to better inform you. And again, that's data should be publicly available regardless on our website. So if you haven't seen it, it will be posted if it's not at the moment. And then we will be looking forward to that September meeting and meeting in person, having some more in-depth conversations as well. Commissioner, I don't know if there's anything else you wanted to say as we wrap up. Oh yes, and also if you volunteered space, please do send it along. And
so that's what I wanted to add. So I just put it in the chat because I'm very excited about exploring other spaces and meeting someplace other than Hartford. So thank you for volunteering that, and thank you for your time today.
Yeah, thank you all. We appreciate your engagement, input, and look forward to talking to you all very soon.